This is being recorded and will be available to watch later on the Little Pussy Surgery website. So do not worry if you miss anything or if you need to leave early. You will be able to watch this on the website as well as our online YouTube channel. We have allocated 15 minutes at the end of the talk for questions. So please feel free to type your questions in the chat box throughout the presentations, and I'll be reading them out to Dr. Cheung at the end. Also, to make sure everyone can hear clearly and avoid any interruptions, please keep your microphones and cameras switched off during the session. Please remember that. And finally, please do not share any personal information in the chat box, as this session is being held in a group format. So now, the exciting bit. It's my pleasure to introduce you to our speaker for this evening, Ms. Elaine Cheung, a consultant obstetrician and gynecologist with the Royal Free London NHS Trust. Dr. Cheung has dedicated her career to advancing women's health through both clinical care and education. Her expertise spans a wide range of areas, including menstrual disorders, endometriosis, sexual health, menopause, and pre-conceptual care. And she is also a fellow of the Royal College of Obstetricians and Gynaecologists, recognized for her outstanding contributions to the field. Tonight, Dr. Cheung will be helping us better understand menopause, what happens during this important life stage, what symptoms to look out for, and most importantly, how this can be managed effectively. So it's a lot in a very short amount of time. She's going to do a wonderful job. Her talk will touch upon hormone replacement therapy, or HRT, exploring its benefits, potential risks, and how it can play a key role in supporting women's long-term health and well-being during and after menopause. So without further ado, please join me in welcoming Dr. Elaine Cheung. Dr. Cheung, over to you.
Today we've got about 45 minutes to have a brief overview of what it is. Thank you very much for the organisers for inviting me to speak today. So today's topic is on understanding and thriving through the menopause, which is something all women are going to have to face some point in their life. So my name is Elaine Cheung, and I'm a consultant obstetrician and gynaecologist at Barnet Hospital, which is part of the Royal Free Trust, and I've been there on and off for almost 17 years. So the topic of menopause is enormous. We can easily have a week-long just about it. So today we've got about 45 minutes to have a brief overview of what it is, the common symptoms, along with the health impacts. I'm going to briefly talk about HRT and the alternatives. No talk is complete without mentioning about lifestyle measures and well-being, as it's not all about drugs. And ultimately, this is to empower women to navigate through this challenging stage of life. So what is the menopause? So in short, it's essentially when our ovaries retire. The ovaries are responsible for producing a variety of hormones, but the main ones are estrogen, progesterone, and testosterone. Throughout our reproductive years, these hormones have a cyclical rhythm with peaks and troughs, as you can see here, depending on which part of the menstrual cycle we're on, and that's what gives women periods. And the menopause is the natural end of the menstrual cycles due to the decline of these hormones. And it's a retrospective diagnosis, which means we can only tell we've been through it once it's been 12 months after the last period. And it is actually just one day, so that'll be menopause here. Typically, it occurs around about 45 to 55 years old. And in the UK, the average is 51 years old. However, the perimenopausal time is this phase here in pink, and this is when, before the last period, when the hormones start to decline and fluctuate, which is the cause of the perimenopausal symptoms that some women have. And this can occur anywhere between 2 and 10 years before the menopause, on average about 7 years. So what do these hormones do? So estrogens have multiple roles within the body, but its main role is in the supporting of bones, so particularly peak bone mineral density, skin, so keeping it supple, elastic, and the brain and heart effects, and of course the reproductive health. Progesterone has also lots of roles, but in a nutshell, it is there to balance the estrogen effects. Testosterone is there for energy, sex drive, and possibly mood as well. And it's these three main hormones that fluctuate and decline in the perimenopausal state. Because of the various levels of the hormones and each person's constitution, there are a huge variety of symptoms recognized in the perimenopausal time. So some people have nothing, they literally have their last period one day and that was it. Some people have more typical ones, which are the vasomotor symptoms like hot flushes or flashes, that's known in the USA, and night sweats, and these can lead to sleep problems. Mood swings, anxiety, and brain fog are also common concerns. Women may experience vaginal dryness and therefore pain during sex, as well as reduced libido. More subtle presentations are often things like joint pains and general fatigue. To add insult to injury, weight gain is very common around this time, and typically the extra weight settles around the abdominal area. And this is thought to two reasons. So one, due to the decline of the hormones, the fat is now stored in a different way, so around the abdomen and visceral fat, in fact, instead of the hips and the thighs. And two, there's some emerging evidence that women become more sensitive to cortisol during this time. Now, cortisol is the stress hormone which is released in times of mental as well as physical stress. So, for example, from lack of sleep. So you're already not sleeping, you become more stressed, and then you put on weight. So the perimenopause can impact women in multiple ways, including physical concerns, such as feeling very tired, aches and pains, emotional problems where we have increased levels of anxiety, loss of confidence. In cognitive aspects, it's common to have poor focus, being forgetful, having that brain fog. Our relationships can also suffer from lack of intimacy, maybe due to a low sex drive or from pain or from a general lack of understanding about what women are going through. And these can all impact on our work, such as absenteeism, where the woman is too ill to go to work, so maybe they had a terrible night's sleep, or presenteeism, so they're able to go to work, but they're less productive. So overall, it's a challenging time for many women, especially when it coincides with the height of our careers. And of course, it has huge impact on society and the economy. So around 1 in 10 women stop working due to the menopause. And it's estimated that UK loses £10 billion per year from lost productivity. And so many workplaces are now beginning to have a lot more talk and focus around how to support women going through the menopause, which is a very welcome initiative. So we've talked briefly about the short-term effects that the menopause can cause on a woman's day-to-day life, but there are actually also longer-term health impacts. During the perimenopausal time, there is a sharp decline in bone mineral density in women. And for some women, this may be enough to tip them into the osteoporotic range, where the bones become brittle. Now, the statistics are that 1 in 3 women will be diagnosed with osteoporosis in their lifetime. Women are twice as likely as men to break their hips. And if you do break your hip, you have a risk of dying of around 30% in the first year. And after this fracture, 50% of people will never get back to their baseline. So our bones are incredibly important, but it's often something we don't really think about, especially in our younger years. Another long-term effect is the effect on the cardiovascular system. After the menopause, cardiovascular disease is the leading cause of death in women, responsible for 30% of all deaths. And this is likely secondary to the changes in the lipid profiles of the cholesterol, as well as increased insulin resistance, which are all related to the changes in the hormones. There are a number of studies now showing that the earlier the menopause, the higher the risk of a woman developing dementia. And the mechanism of why this is not really clear, but taking HRT seems to reduce the risk of Alzheimer's and all forms of dementia. In the later menopause, there is atrophy or shrinkage of the reproductive organs, and this results in something called genitourinary syndrome of the menopause. It has many names, including urogenital atrophy, vulvovaginal atrophy, and this can also cause vaginal pain and bladder symptoms. You can also get skin thinning, reduced elasticity, reduced muscle strength, which means that we get more joint pain and osteoarthritis after the menopause. So patients often ask me, how do they know they're in the perimenopausal state? And actually, it is a clinical diagnosis. So for women aged 45 years or older, if they're having perimenopausal-like symptoms, whether or not they have menstrual changes, and that tends to be lighter, shorter periods or skipping periods altogether, then we can diagnose them to be in the perimenopause and start treatment if necessary. And there's no need for a blood test. If you're between the ages of 40 to 44 and we're not entirely sure if these symptoms are related to perimenopause, then you could consider some hormonal blood tests, and typically we would be doing something called FSH, follicle stimulating hormone. And if you're under the age of 40, we would certainly recommend blood tests because it could be something else and further investigations. So what is HRT, hormone replacement therapy? Well, it is designed to replace estrogen that has been lost and combined with progesterone and sometimes adding back testosterone. Its aim is to relieve the menopausal symptoms, and particularly the vasomotor symptoms, plus all the other benefits such as preventing bone loss. And it comes in a variety of forms like tablets, patches, gels, sprays, and vaginal preparations, and it is tailored to each woman's needs and their medical history. So estrogen is the main hormone that relieves the menopausal symptoms, but it can't be used alone because if you do, you can have overgrowth of the lining of the womb, so overgrowth of the endometrium. And if you leave that untreated, that can even turn into cancer. So you need to have progesterone added on top if a woman has her uterus. If a woman has had a hysterectomy, then you are very unlikely to need progesterone, but it depends which type of hysterectomy you've had. And if you're having only estrogen only HRT, then actually that has generally a lower risk profile and it's easier to take. But as the vast majority of women have their uterus, then the vast majority of women are going to need a combined preparation. Still happen. Then she'll be commenced on sequential or cyclical HRT, which is continuous estrogen and then progesterone for half the amount of time. So, 10 to 14 days in a 28-day cycle. And usually we would give it for probably around about 12 days, somewhere in the middle. And this will cause a monthly withdrawal bleed. If the woman is already menopausal, so they've had their last period, then they would usually be started on a continuous combined preparation, which is the same dose of estrogen and progesterone every day, and there will be no monthly bleed. Now, when to change from sequential to continuous, well, it's usually around about 2 to 5 years of taking sequential HRT, or if the monthly bleeds stop, or if the woman is over the age of 54 years old, as 80% of women will be postmenopausal by that point. And there are generally two types of the estrogens, and the most common and recommended type of estrogen in modern HRT is estradiol, so 17-beta estradiol, which is body identical and has the same molecular structure as the estrogen that we naturally produce in our ovaries. And this is often derived from plants such as yam or soy. Then there are the older synthetic types of estrogens, like the conjugated estrogens, which were, well, the other name for it was Premarin, which was derived from pregnant horse urine. So that's where the name comes from, pregnant mare urine, Premarin. And this is much less commonly used now. And these were actually responsible for the sort of side effects and scare stories of old about HRT. Estrogen can be administered in several ways depending on personal preference and the health profile. So tablets, and the top right here, these are a tablet taken once every day. And this method can slightly increase your risk of blood clots compared to, say, transdermal options, but some women prefer patches are applied to the skin, so usually below the belly button, and it changes depending on which brand. And then you have the gels. You have one 3 pumps, usually 2 pumps applied to the skin. So it's usually around the arm or the thigh. And then you have the sprays now, Lenzetto being the only one. That's also applied to the forearm. And these last two, so the gels and the spray, you need to allow them to air dry before you get dressed. And you can make sure you have to wash your hands and you don't touch anybody else, including pets and children. And these last three, so the transdermal preparations, so gels, patches, and sprays, these don't increase the risk of blood clots at all. Progesterone, there are generally 2 types. You have the natural or synthetic type. So the natural or micronized progesterone is body identical. And the most common one is utrogestan, which is a licensed HRT in the form of an oral pill. Cyclogest can also be used, but because it's not really licensed for HRT, it's not commonly used. And these have a very favorable safety profile, and they have generally a lower risk of breast cancer. They can also have a sedating effect, which can be helpful for some women, especially if there's problems with sleep and anxiety. Then there are the synthetic forms, and these are technically called progestins. So you have medroxyprogesterone acetate or Provera, and this is used as an oral form. It's really quite helpful to treat endometrial hyperplasia with that. Norethisterone, these can be oral tablets or combined in patches with estradiol, like Everil Conti, which is very common, or in tablets like Elest Duet Conti. And then there's dydrogesterone. And this closely resembles the natural progesterone and often has fewer side effects. And previously, it was only known to be combined with estradiol and Femiston. But actually, as of September, it can now be used as a standalone progestin. And then levonorgestrel, this is the hormone in the Mirena coil. And it's also available combined with an estradiol in the patch, such as Fem7 Conti patch. So a typical regime would be something like transdermal estrogen, so either through a patch, spray, or gel, because this has the overall lowest risk profile, and some form of micronized progesterone to the utrogestan, or even the Mirena coil. However, there's about 20 different types of preparations available, and that's because it is not a one-size-fits-all, and different women will need different combinations to suit their lifestyle and their response. It is also important to bear in mind that as the estrogen dose increases, you also need to increase the progesterone component to counteract its effects. You may have heard of bioidentical compounded HRT, which is custom-made HRT mixed in a private pharmacy. It's often marketed as being more natural or safer than the conventional HRT, but there is actually no evidence for this. The hormone levels can vary quite a lot, and because there's no guidance or evidence for their effects, we really can't tell you if it's safe. There is no clinical evidence that they are better than the more licensed HRT, and both the National Institute of Clinical Excellence and the British Menopause Society, which are the two recognised bodies who form the clinical guidelines for menopause and therefore have the most expertise, both of them advise using against this form of HRT due to the lack of regulation and evidence. For those with vaginal symptoms, vaginal estrogens can be used alone or with systemic HRT. It is very low dose and has minimal absorption in the body, and it works just in the vagina alone. And these are very safe to use long term. And if they're used alone, you don't need to have progesterone with them. And they come in a variety of forms, such as the creams. They've got the Ovestin or the estriol cream here. It has an applicator. And you've got the here you've got Vagifem, Vagirux would be another one. And you've got the E-string, which is a pessary that stays inside the vagina for 3 months at a time. On top of vaginal estrogens, or instead of using them, if there is vaginal dryness, soreness, or discomfort, women can also use vaginal moisturizers and lubricants. So vaginal moisturizers are usually used about 2 to 3 times a week, depending on the brand, and they help maintain the vagina to be kept moist and elastic. And here are a few brands here. You've got Replend at the top here, Yes, and Silk, and they'll have very appropriate sounding names. And you can also use lubricants, usually used during sexual activity, and these can be either oil or water-based, and sometimes using a combination of both of them can be quite helpful. Now, not everyone needs to take testosterone, but for those who do, its primary indication is for people with low sexual desire, so low libido. Anecdotally, though, it does also seem to help with energy levels. Interestingly, in the UK, there are no licensed female testosterone products, and all the products we use are actually made for men. So the amount that we use is very small. And there are actually only two in the UK. So you've got Testogel at the top and Tostran. And they both come in little canisters or sprays, and you use them on the skin every day. Testosterone levels need to be monitored every few months with blood tests. Otherwise, you can risk having quite unpleasant side effects, such as greasy skin, excess hair, and acne. So the benefits of HRT are that it's very effective against hot flushes and mood changes. Secondary to that, hopefully, it also improves sleep, concentration, and sexual well-being. Some of the other benefits are on the bone protection, reducing osteoporosis and fracture risk, and it very likely improves urinary and vaginal health by reducing things like urinary urgency and recurrent UTIs. There is also the improvement of the skin elasticity and moisture, and possible benefits on joint pains. And there is more and more evidence that there is no worsening of cardiovascular disease. And in fact, it seems to be protective. The current relationship with HRT and dementia is more complex, but in general, it seems, or the studies seem to suggest that starting HRT earlier seems to reduce the risk of dementia, or at least give you better cognitive performance. But if it's started late, and by late we mean after the age of 65 or more than 10 years after the menopause, in fact seems to have an opposite effect. So HRT seems to increase the risk of dementia. So this is another big area of research into HRT, and that is on the timing of when to start HRT. Yes. With the newer preparations of these, there are much fewer side effects. There are some mild effects, such as breast tenderness, headaches, nausea, bloating, mood swings, or irregular vaginal bleeding, particularly in the first few months. But these tend to settle down after about 3 to 6 months of starting the hormones. If these problems continue, maybe you need to talk to someone to change the preparation or change the dose. Some of the more serious effects that women tend to worry a lot about is breast cancer. Now, there is a slight increased risk of breast cancer with long-term use, and here we're talking about more than 5 years. And this risk does increase the longer you take HRT, but it begins to decline as soon as you stop taking it. It's worth bearing in mind that if you only need to take estrogen HRT, so not progesterone, there's actually no increased risk of breast cancer at all. After the age of 50 in the NHS, everyone gets invited to 3 yearly mammograms, and I would strongly recommend going to that. So just a little bit more about breast cancer risk. So this infographic was taken from the NICE guidance on the menopause. And here it is about the incidence of breast cancer per 1,000 women aged 50 to 59. So at the top here, you have, in general, if you've got someone who is, people who are not taking anything at all, you would have 23 cases of cancer per 1,000 women. If you take HRT, this increases it by 4. So instead of 23 per 1,000, you have 27 per 1,000. Those that are quick on the maths, that you'll find that, so that's a 0.23% to a 0.27%. And look at the third column here. If in fact, if you only use HRT that only with estrogen only, you actually have 4 fewer cases of breast cancer. And then the rest of the slide is also to compare relative to other things. So, for example, if you take the oral combined hormonal pills, that's the pill for contraceptive pill. Again, it's an extra 4 cases. If you drink 2 or more units of alcohol a day, that's an extra 5 cases. If you smoke, it's an extra 3 cases. And if you are overweight or obese, so it's a BMI equal or greater than 30, in fact, your risk doubles from 23 to 46 cases per 1,000. So that's really quite a large increase. And then there's some hope here. So at the bottom here, if women do at least 2.5 hours of moderate exercise per week, you can actually have fewer incidences of cancer, so 7 fewer incidences of breast cancer. So when you come to HRT, the overall effect here is really quite small. So the oral forms of HRT can slightly increase the risk of blood clots, which are deep vein thrombosis, and that's usually in the legs or in the lungs, particularly in the first year of use. But if you're using transdermal preparations, so that's the patches, gels, and sprays, there is a 0 increase. There is no increased risk of weight gain or heart disease if you start HRT before 60 years old. And in the vast majority of women, the benefits of taking HRT will outweigh the risks. But not everybody can take HRT, or at least need some specialist advice. And those people who can't take it are, for example, people who have current or recent breast cancer, or if you have known or suspected estrogen-dependent cancer, for example, endometrial cancer. Other criteria are things like undiagnosed vaginal bleeding, because again, the worry of endometrial cancer, that needs to be investigated first. If you've had a blood clot before and you're not taking any blood thinners, you probably shouldn't take it. But if you are on blood thinners, you can probably take HRT, probably a low dose form, and that would be absolutely fine. Because estrogens are metabolized in the liver, if you have severe liver disease, oral HRT is not recommended, but transdermal is probably okay. And if you have uncontrolled high blood pressure, it's best to investigate that and get that treated first. And then there are some very rare metabolic problems, which I won't go into. So for women who have menopausal symptoms and they can't take HRT, or they don't want to take HRT, there are alternatives. There are the pharmaceuticals. So these are drugs like SSRIs and SNRIs, so typically something like venlafaxine, which are actually antidepressants, but they do have quite okay evidence that they can reduce vasomotor symptoms. Clonidine is another drug that can be used for hot flushes and night sweats, but its actually main purpose is to reduce blood pressure, although it's actually not very good at doing that either. Herbal options are very popular, and there isn't one product that fits all. So you've got black cohosh and red clover. So this is black cohosh and this is red clover, pretty flowers. And there is some evidence that they can reduce hot flushes, but you've got to be careful if you're going to use it if you have a hormone sensitive cancer, because they potentially can cause some problems. So consuming soy products, so that's tofu, soybeans, and soy milk, that can be beneficial, but you probably have to take quite a lot. And there are some other herbal products which are used for their calming or energetic effects, such as ashwagandha, rhodiola, eleuthero, and there's plenty more like sage, St. John's wort. I could probably do a whole talk just on the alternatives. There is good evidence that cognitive behavioral therapy reduces hot flushes and improves sleep. In fact, it is one of the most effective non-hormonal approaches for managing the psychological and physical symptoms of menopause. And it's about reframing negative thoughts and developing coping strategies. And online, there are really quite a lot of resources, and there's quite a few apps. You may have heard things like Headspace, Calm app, or Sleepio that are all really quite helpful. And then there's decent evidence that acupuncture can also help with vasomotor symptoms. I would encourage you to seek help if you are having severe symptoms that's affecting your daily life, or you have persistent bleeding or pain, especially after 3 to 6 months, or mood changes or low libido, or if you're concerned about the side effects, or you're just not responding to whatever you're taking. There's always help available. If you are on HRT, the first review is usually after 3 months. Once you are settled, it's usually every year. And during these reviews, you'll have your symptoms will be checked, whether there are any side effects, and whether your current preparation is right for you. And don't forget, mammograms are every 3 years, and that's also part of your health check. But the perimenopausal time is not just about taking drugs. It's also about which can significantly alleviate our symptoms and promote long-term health without any need for HRT. It's really important to exercise regularly for strength, balance, and its cardiovascular benefits. But what I also mean here is of the weight-bearing kind, to improve our bone health. It also helps to manage the weight gain often associated with menopause, improves your sleep quality, reduces cancer, as we saw, and boosts moods by releasing endorphins, and maintains your muscle mass. And we should be aiming for 150 minutes, that's 2.5 hours, of moderate intensity aerobic exercise per week, or 75 minutes of intense aerobic exercise, plus 2 sessions on strength training. So we're talking about lifting weights. We should also consider our diets, making sure that they're supplemented with enough calcium, vitamin D, such as that found in dairy products, green leafy vegetables, sunlight, oily fish. We should be aiming for a diet rich in fruits and vegetables and whole grains, and not only for the nutritional benefits and fiber, but also to support the gut microbiome. Now, this currently has a huge amount of research into it, and it appears to be implicated in many disease processes, and it's probably a big contributor to the menopausal symptoms. Magnesium has also been shown to improve sleep quality, help with mood and stress relief, as well as support your bone health and cardiovascular health. And the one that's recommended is magnesium glycinate, and that's opposed to the citric, oxalate, and malate forms, because it's much better absorbed and you have much less gastrointestinal effects. Stopping smoking, reducing caffeine, not drinking any alcohol, and properly reducing spicy food can also minimize the frequency and severity of hot flushes and night sweats. Maintaining a healthy weight or losing weight if you're overweight is crucially important for multiple benefits in the body. And we need to develop consistent sleep schedules. So good sleep hygiene, whereby we go to sleep and wake up at similar times every day. You can have up to 30 minutes variation. And then there are other things that we can do to help get a restful night's sleep, such as keeping the bedroom cool, so not wearing too many layers, keeping it dark, so maybe investing in some blackout blinds or an eye mask, and reducing our screen time at least an hour before bed. And I think that's a difficult one for many people. But by overhauling our lifestyle measures alone, that is often enough for women to navigate through those challenging years of the menopause. As you can imagine, the menopause can have a huge effect on a woman's confidence, and thriving through the menopause involves building strong mental resilience. Stress management techniques are very useful for managing mood swings, anxiety, and irritability. So practices such as meditation, mindfulness, deep breathing exercises, cognitive behavioral therapy can all help regulate our emotional responses and reduce anxiety. Connecting with friends and finding support groups can provide valuable outlets for sharing our experiences, bouncing practical tips off each other, and finding solidarity. And be kind to yourself. Treat yourself with the same kindness and understanding you would show a friend who's going through a difficult time. Menopause is a workplace issue, and often simple low-cost adjustments can help employees manage their symptoms and continue to thrive professionally. So employers have a legal duty under the Equality Act and the Health and Safety at Work Act to not discriminate and to ensure a safe working environment. So you can have simple adjustments like having a desk fan or moving your workstation closer to a window for ventilation, having easier access to break rooms or bathrooms, adapting your workwear if you have a uniform, and maybe thinking about flexible working hours and maybe starting later if you're anticipating a really bad night's sleep. And we can have those open conversations about menopause, about your experiences and what adjustments can be made with employers. We can take the next steps by championing and normalizing menopause through training sessions, campaigns, and making sure that menopause policy is well publicized. There are a huge range of resources which are growing every day to support women going through the menopause. And we can choose to thrive through it by focusing on well-being and health, prioritizing our work-life balance, our nutrition, making social connections, and seeking support when necessary. So in summary, the menopausal transition is a natural life stage. It's inevitable. If you choose to take HRT, it is generally safe and effective for most women. Thriving through menopause is about actively embracing this significant life stage by making lifestyle adjustments, using psychological strategies, and having a strong social support. This transition can become a period of empowerment and vitality so that we can all unleash that natural self-confidence and energy that we all have. Thank you for listening. These are my contact details. That's my website and my email address. And these are also some of the other private clinics that I work at.
Thank you so much, Doctor. That was really helpful. We have quite a few questions coming through, if that's okay.
Absolutely.
Yes, I'll read some to you, so I'll go in order. We have Entente asking, she's saying, I am at high risk for breast cancer. Will I be able to take HRT if needed? I take the micro pill. Will I be able to spot the menopause symptoms, or does it artificially postpone it? So 2 questions there from her.
So, okay, so I'll start with a slightly easier one. So, taking any form of contraception, so the hormonal contraception, it does not postpone the menopause. It can mask it, meaning you may not know you've gone through it, but it doesn't postpone it. Now, when people talk about high risk of breast cancer, it depends very much what we're talking about here. Are we talking, do you carry the BRCA genes, 1 or 2, or is there a strong family history around it? If there is, it's mostly a women's choice. You can take HRT, but we would start off with a very low dose form, and we would use the ones which have the lowest risks. So we're using some sort of transdermal estrogen and the micronized progesterone. To be fair, that's not the right preparation for everyone, but that would be probably the ideal form.
Okay. The next question is from Wendy. She's saying, I am still having regular periods and I am on combined both estrogen and progesterone for 24 out of 28 days. Should I only be taking it for 14 days?
Well, it depends where I take it for 24 days out of 28. So the progesterone component is the bit that usually gives all those slightly unpleasant side effects. So the breast tenderness, the nausea, the bloating, that's actually all comes from the progesterone. So that's why, ideally, if we didn't have to take it, that would be great. But because we have to take it for the endometrial protection, minimum, you have to take it for at least 10 days per 28 days. So if there's a particular reason why you're taking it for 24 days, it's fine if that's what you're taking, but you only really need to take it for a minimum of 10, but we usually say something in between 12 days.
We have another question, thank you, doctor, from Yemi. She says, it seems like you are better off not taking HRT if you are obese, even if you engage in mild physical activity at least twice a week.
Well, I mean, you being obese raises your risk of everything, quite frankly, of many cancers, heart disease, strokes, you name it, it's all there. And if HRT really does actually reduce your cardiovascular risk, it's actually probably better to take it than not, to be honest. The risk is already there. It's and really the menopause is not just about HRT, it's also a lifestyle measure. It's literally overhauling your entire life and suddenly bringing into focus your health. And that's certainly, my experience anyway. Suddenly health has become really important, so I think you can take out HRT even if you are on the heavier side, and it will still give you symptomatic relief, and I think it will still give you the bone protection that ironically you can have quite low levels of vitamin D if you are heavier, which not many people are aware of that, but that does happen as well.
So on to the next question. Sunflower, my cholesterol has been increasing the past few years after losing over 3 stone in weight and not drinking or smoking. Good job, well done. I think this is linked to perimenopause, as I've been suffering with many symptoms for many years now. If I started HRT, can this improve my lipids and lower my cholesterol to a normal range?
It can probably help, but it wouldn't be the primary objective of why we would use that. It certainly wouldn't make it worse. So I think, and unfortunately, it's the way our hormones change. I mean, it's quite complicated, but it changed because of the sex hormones they're all steroid hormones. They change the steroids in our body.
Mm.
And steroids are the things that causes all sorts of things, like how our fat is
Yeah.
deposited, where our fluid is shifted. Um, it's an awful thing. So I don't think it makes it worse.
Mhm.
I don't think it can, we wouldn't use it to improve it though, but I don't think it'll make it worse.
Okay, we have Bebs saying, I am in perimenopause. I have not had a period for 8 months so far. About 3 years ago, I was diagnosed with a fibroid in my uterus and a polyp in my cervix. This has not been removed. How does perimenopause affect fibroids and polyps with the change in hormones?
So, but they're two different things. So fibroids grow in response to hormones.
Mhm.
And so after the menopause, because the drop in hormones, the fibroids will actually shrink a little bit. They will always be there, but they will shrink a little bit.
Mhm.
Polyps are usually little growths. Sorry, that was polyp in the cervix. I mean, I gotta say, any lumps and bumps, and what I mean by that is polyps, really. If
Mm.
it's found in the endometrium, in the endometrial lining, or in the cervix, ideally it should be removed. The one on the cervical polyps are very easy to remove. You know, you don't need to be put to sleep for it. I would always remove them because, unfortunately, in the older woman, there is always a chance of something sinister going on. So I would recommend you have that removed. Um, so what was the question? So does the menopause affect polyps? No, not particularly.
Okay, yeah, that was the question. Um, we have Diane, excuse my accent. She's saying, I am currently suffering with overwhelming symptoms. I went on HRT about a year or so and came off it because I think my expectations were too high. Uh, I also do not think I was well informed about. So it's more than a question, it's a comment. And
Mm,
really glad you're here. And
yeah.
as you said, doctor, is so
So
important.
so everybody's HRT regimen has to be personalized because if you find that the HRT doesn't help with your vasomotor symptoms, and that's the thing that it's best at, then you need to either change your dose um, by increasing it or maybe change your preparation. So just because it didn't work for you the first time doesn't mean that's it. It's never going to work because there are so many different preparations out there.
Mm.
Um, so no, do persevere with it. You don't have to take it if you don't want to.
Mhm.
Can HRT make you feel back to normal? Probably not.
Mm.
But it can certainly make you feel a lot better.
Mm. And
Well,
talking
normal.
about talking about HRT, we have Hina asking as well. She says, I had a hysterectomy due to fibroids in my early 40s, currently getting symptoms such as hair loss, plantar fasciitis, dry eyes, ears. If I started HRT, would these things get better?
Probably. So hair loss is a big trigger. So that often happens in the menopausal period. HRT won't give you that healthy, luscious hair again, but it will at least stop the sort of hair loss from drastically happening.
Mm.
Plantar fasciitis, again, it's about the joints and the ligaments, you know, coming under strain. So yes, that would help. And your dry ears and eyes, maybe not, but people do tend to get a little dry skin, so it can be related. So I think HRT will help.
Mm.
You can always try. I mean, if you've had a hysterectomy and they took away the cervix, you can very safely take estrogen only HRT, which is really it's almost like almost I wouldn't say risk free, but it has very minimal risk. But you've got to make sure you have the cervix taken away. If the
Mm.
cervix does remain, you sometimes what we do, because you can have a little bit of endometrial tissue left in the cervix. And if that happens, then you can trial sequential HRT for say 3 months and see if you bleed. And if there's no bleeding at all, then you can probably safely say that you don't have any endometrium
Mm.
and
Mm.
just go on the estrogen only.
Mm. And she's also asking if that's okay, if it's best to take HRT early to prevent osteoporosis, which is related to obviously plantar fasciitis, even if other symptoms are not very present.
So HRT isn't primarily given for osteoporosis. Having said that, it is very good to take it. The other medicines for osteoporosis have essentially tons of side effects. So your bisphosphonates can have quite a lot of side effects. So if you ask your rheumatologist, they actually will often tell you that actually probably HRT would be a good thing.
Makes sense. And we have one last question from Sunflower. She's asking, can HRT help to increase energy levels and fatigue without needing to take testosterone?
Yes. Yes, that's the idea. Most people do. Sometimes what we find is you often need to take a transdermal, so the estrogen needs to go through the skin, so the patches, gels, or sprays, and that's because again of the way that the hormones interact in the body. If you take it orally, it can actually suppress your own natural levels of testosterone. So if you take it through the skin, the estrogen through the skin, it can just help the testosterone levels come back up to the normal or less suppressed.
Mm-hmm. Makes sense. And we have one last comment or question. Diane is asking, I think we had it at the end of the presentation. She's asking if you
Yeah.
offer private consultations and how to contact you. Dr. Cheung, could you please put your details on the chat before you leave, in case anyone...
Absolutely.
I think that's all the questions we have for now. Maybe we give it 30 seconds in case anyone else has any other question. I'm gonna keep the doctor here with me till you're sure. You'll just receive the details from the doctor as well, should you want to get in touch. Thank you, Danielle. They love your presentation, doctor. Hopefully we see you in the next webinars as well.
Thank you.
I think it's all thank yous for now. Thank yous.
I know it's a late one tonight.
Yes, but very clear and informative. Thank you so much. Great presentation. So good feedback. So if that's okay. Oh, there's one question. I just want to say this has answered so many questions. Thank you so much for arranging this. So that's excellent. So if that's okay, ladies, I will wrap up. And if that's okay with you, doctor, you're getting lots of clappings. So good, great job. So if that's okay, I will conclude. Well, first of all, thank you so much, Dr. Cheung, for such a wonderful and insightful session. I have to say, I'm not looking forward to what's about to come for me, but no, it's an early call. And thank you everyone who joined us this evening and share your questions. We really hope you found this webinar helpful and that it's giving you a clearer understanding of menopause and the role of HRT in women's health. Before we finish, I would like to take a moment to invite you all to join our patient participation group here at Little Bushy Surgery. We are a friendly group of patients who work together with the practice to help improve services, share feedback, and support health initiatives, including events like this one tonight. So it's always great to make a real difference and have your voice heard in shaping local healthcare. So we are very much looking forward to hear from you. I will be leaving the details here if you would like to get involved. And also, please get in touch with us for any questions that you might have. And I think that's all. Thank you again for being part of tonight's sessions. Let me just send the details here. Thank you again for being part of the session, and we look forward to seeing you at our next webinar. And have a lovely evening, everyone. And thank you so much, Doctor. It was great.
Thank you. Thank you very much.
Thank
Good night,
you.
everyone.
Thanks.
Bye.
Bye.
Bye, ladies.
Bye bye.